Dear audience, ladies and gentlemen, in the next few minutes, I would like to show you my 3-month progression. This is the summary title of my PhD topic. My name is Endre Botond Gagyi. I'm a first-year PhD student at the Center for Translational Medicine. My supervisor is Bálint Erős, my SMS is Mahmoud Obeidat, and my statistician is Daniel Sándor Veres. My vision regarding to this topic is that we can reach a state where we can prevent most of the patients from the recurrence and the progression of acute pancreatitis, and my mission is to reduce this recurrence and progression rates. A quick overview of my research topics. The first one will be a systematic review and meta-analysis, and it is called The Risk Factors of Acute Pancreatitis Progression into Recurrent Acute Pancreatitis and Chronic Pancreatitis. The second one will be a protocol of a prospective observational trial, and its working title is there beta cell dysfunction in acute pancreatitis? But let me briefly introduce the first one. The incidence of acute pancreatitis varies globally, affecting from 5 to 80 people per 100,000 and appears to be increasing around the world. Most acute pancreatitis can be completely recovered after standard treatment, but a proportion of patients eventually develop recurrent acute pancreatitis up to 35% or chronic pancreatitis up to 24%. On the right, you can see the sentinel acute pancreatitis event model by Whitcomb et al., which states that a sentinel acute pancreatitis event sensitizes the pancreas to recurrent acute pancreatitis as ongoing stress source drives various inflammatory responses to cause chronic pancreatitis. In order to reduce this recurrence and progression rates, it is essential to know all the contributing factors of progression. However, data on the risk of developing RAP and CP and factors affecting disease progression have been heterogeneous. There are already known risk factors such as alcohol consumption or smoking, but at the same time there are unknown factors such as BMI or hypertension or etc. whose role in the progression of acute pancreatitis has not been investigated. Therefore, our aim is to comprehensively assess and objectify all the potential risk factors that can contribute in the progression of acute pancreatitis into recurrent acute pancreatitis and chronic pancreatitis. As this study examines the risk factors of acute pancreatitis progression, we use the PO framework for posing the question. So our clinical question is, what are the risk factors of acute pancreatitis progression into RAP or CP? The population will be patients with first episode of acute pancreatitis or patients with RAP. The exposure will be the presence of the risk factor and the outcome recurrent acute pancreatitis or chronic pancreatitis. Our hypothesis is that in the presence of the risk factor, the odds or risk for developing recurrent acute pancreatitis or chronic pancreatitis are higher. The clinical implication is that if we can identify any modifiable risk factor, we can reduce this, the recurrence and the progression rates of acute pancreatitis. To achieve our goal, we have done a systematic search in 3 big databases using this search key. Here you can see the flowchart of our selection. Out of 23,000 articles, we found 573 after the title and abstract selection, and now we are doing the full text selection, and 60% is already done. Our second project will be a protocol of a prospective observational trial. Let me introduce this background. We know that acute pancreatitis is the most common pancreatic disease responsible for the development of diabetes mellitus. And it is complicated by pancreatic necrosis in 10% of cases. We also know that the most relevant mechanism of diabetes mellitus after acute pancreatitis is considered the loss of pancreatic beta cells due to pancreatic necrosis. And we also know that fasting C-peptide is a useful marker of pancreatic beta cell function. Therefore, our aim is to understand the changes of C-peptide levels during acute pancreatitis. What is the big picture? What we want to do is to measure the C-peptide levels during acute pancreatitis. But why is that important? Well, our vision is that C-peptide might be a useful as a biomarker for predicting post-acute pancreatitis diabetes mellitus. This can be true if two conditions are met. First, we can detect a significant decrease or increase in C-peptide levels during acute pancreatitis. Second, we can show that the group with significantly decreased or increased C-peptide levels develops significantly more post-acute pancreatitis diabetes mellitus in the short or the long term. So the concept would be a transient C-peptide level decrease during acute pancreatitis leads to an increased risk of post-acute pancreatitis diabetes mellitus. This study will give an answer only for the first condition. So our clinical question is, does the severity of acute pancreatitis has an effect on C-peptide level? The population will be general acute pancreatitis patients without pre-existing diabetes, etc. The exposure will be different severity of acute pancreatitis, and the outcome will be C-peptide level changes on admission, on discharge, at follow-up, etc. We have two hypotheses. C-peptide blood levels decrease in severe acute pancreatitis, and second, recovery from severe acute pancreatitis may result in improvement of C-peptide levels. The clinical implication is that finding a decrease of C-peptide levels may subsequently help in the early identification of patients at high risk of post-acute pancreatitis diabetes mellitus. This is just a preliminary inclusion and exclusion criteria. We will include all patients with a diagnosis of acute pancreatitis without diabetes mellitus with a normal HbA1c. We will exclude all patients with severe malnutrition, severe obesity, low BMI, or diabetes mellitus. A quick summary of my research topics. I would like to finish the first one by the end of March and the second one by the end of July. And this is the quote I chose. And thank you for your attention.
Okay, nice presentation. Thank you for your first topic. Is there any reason why you choose to separate the two groups regarding recurrent acute pancreatitis and chronic pancreatitis? Are you expecting to find different risk factors or just different?
So we actually didn't separate the two groups. This is just for a visualization because we will look at the risk factors between the REP and the CP.
I see.
Isn't it possible that the diabetes pre-existed before the first occasion of acute pancreatitis? Did you include for example, the hemoglobin A1C to see if there is or some sort of a...
For the first project?
Yes. As a criterion?
Yeah, it can happen, yes. So we will include consecutive acute pancreatitis patients, and yes, among this there are cases with pre-existing diabetes.